Great pleasure always to be among you all in this prestigious gathering. The title of my talk is MIVAP, a reliable surgical procedure for detecting all parathyroid patterns or all patterns of parathyroid adenoma autofluorescence on NIRAF, a prospective single surgical case series. My co-authors and I have nothing to disclose. Transient hypoparathyroidism is the most common complication of thyroid surgery, with an incidence rate of up to 65% that led to some authorities as considering it as a side effect rather than a complication of the procedure. With the intent of maintaining parathyroid gland function through improved identification and preservation of parathyroid glands in their usual location in situ, several surgical adjuncts have been introduced, one of which is the image-based NIRAF, near-infrared autofluorescence imaging, which detects parathyroid glands in real time during thyroid surgery. In thyroid surgery, NIRAF achieves its primary endpoint, considerably lowering the incidence rates of both post-operative transient and permanent hypoparathyroidism. In surgery for primary hypoparathyroidism, however, the primary endpoint is to enhance biochemical cure and minimize failure rates. The use of NIRAF as an intraoperative optical biopsy capable of identifying the autofluorescence pattern of adenomatous parathyroid glands has not been very promising, and this is mainly attributed to the considerable heterogeneity in the autofluorescence pattern of pathologic parathyroid glands. In a recent study, we've demonstrated the feasibility of utilizing NIRAF imaging in MIVAP without any additional technical difficulties. However, the study was guided by preoperative localization diagnostics, and we also demonstrated the absence of any correlation between the autofluorescence patterns of parathyroid adenomas and their inherent characteristics, site size, or predominant cell type. The same study gave birth to a new pattern of parathyroid adenoma autofluorescence, which is the double cap pattern we described, and in which the adenomatous parathyroid gland appears of low intensity autofluorescence, and we have two bright areas, peripheral areas, described as cap. One represents high intensity peripherally compressed normal parathyroid gland tissue, and the other represents intraparathyroidal adenoma adipose tissue. The primary endpoint of this study was to assess whether we could perform neck exploration using MIVAP, with NIRAF being its adjunct, to detect the various autofluorescence patterns of parathyroid adenomas. The secondary endpoint was whether certain patterns could be considered pathognomonic for parathyroid adenomas and their incidence rates. So if we have exclusive patterns with high incidence rate, then we can cause a paradigm shift in the diagnostic techniques for parathyroid adenomas, replacing the conventional preoperative diagnostic measures of targeted parathyroidectomy with an intraoperative optical diagnostic method. So this was a prospective study in a high-volume center in Jordan, where consecutive cases of primary hyperparathyroidism due to single gland disease were all operated, all had concordant localization. The cases were operated by a single high-volume surgeon, blinded to the results of preoperative localization. Accordingly, cases with non-concordant localization were excluded, so were mediastinal cases, as we know that the depth of tissue penetration of near-infrared is a major limiting factor. Reoperative cases and cases with previous irradiation to the neck were also excluded. The four patterns reported were high and low intensity autofluorescence, cap and double cap autofluorescence. In cases where the surgeon was unable to allocate the parathyroid adenoma, a person in the theater with the knowledge discloses the results of preoperative localization to the surgeon. All procedures, whether blinded or not, were concluded only if intraoperative PTH corrected appropriately. The results: MIVAP had a success rate of 96%. The surgeon missed 4 lesions which had to be disclosed, and half of these were due to high intensity fibrofatty tissue, and the other half was due to low intensity lymph nodes. Ultimately, all resected 72 lesions after disclosure were histologically confirmed parathyroid adenomas. The autofluorescence patterns reported were high and low intensity autofluorescence 20% each, cap autofluorescence 51%, significantly prevailing, double cap in only 4% of cases. The only patterns exclusive to parathyroid adenomas were the cap and the double cap autofluorescence patterns. To conclude, MIVAP is non-inferior to its conventional counterpart for neck exploration with the concomitant utilization of NIRAF imaging. Cap and double cap seem to be the only pathognomonic autofluorescence patterns potentially serving as reliable intraoperative optical diagnostic means. However, with an incidence rate combined being slightly above 50%, these cannot, at the current time, replace the conventional diagnostic methods of targeted parathyroidectomy. Thank you very much.